All right, here we are right at 2:02 Eastern Time. Welcome to the Boston Children's Hospital Computational Health Informatics Program, Machine Learning and AI Work Group. We host a public journal club monthly, and today we have a real treat in that Ben Reis, one of the Computational Health Informatics Program faculty, assistant professor at Harvard Medical School and director of the predictive medicine group within CHIP, is an author on a very exciting study that was just published and garnered quite a bit of press in the New York Times, Bloomberg News, Fortune, and other places. And it's the study that is maybe one of the best examples of the use of real world data held up to the light against clinical trials data and showing some pretty tremendous concordance, in fact, in this case. And the paper that he's presenting today is about the Pfizer COVID-19 vaccine under mass vaccination programs in Israel, and evaluated in a real world setting at national scale. So with that, I'm going to turn it over to Ben.
All right, thanks so much, Ken. Let me just share my screen here.
While Ben's doing that, I'll just remind folks that if you put questions into the chat, we'll leave time to answer them at the end. Some have already started to come in even before Ben started to speak, which is, I think, a very good level, a good indicator of the level of interest in this topic.
Okay, yeah, so thanks so much, Ken. Can you guys see my screen and can you hear me okay?
Yes, it looks great.
All right, great. So thanks everyone for joining. Looks like we have a good turnout. Today we're going to talk about this paper that recently came out. It is one of the first large studies, the largest so far, of the real world effectiveness of a COVID vaccine in a nationwide mass vaccination setting. It focused on Israel, it focused on the Pfizer vaccine. Our co-authors in the study, this was an amazing group effort. So I first want to thank everyone at the Clalit Research Institute, part of Clalit Healthcare. This was a Clalit study using Clalit data in the Clalit setting. I especially want to thank Noah and Noam, who were the first authors of the paper. They're currently also postdocs at Harvard, two of the smartest people you'll ever meet. I also want to thank Ron Balitzer, who is the founder and director of the Clalit Research Institute, a true visionary on a global scale. You'll see why in a few slides. I also want to thank Miguel Hernan and Mark Lipsitch of the Harvard School of Public Health, world leaders in epidemiological studies. And you'll see that this particular study had pretty interesting challenges. Without Mark and Miguel, we don't know how we would have overcome them. So truly a team effort, and here we go. So the way we're going to organize this today, I know there's a lot of questions, so we're going to try to leave time at the end. What we're going to do is start the first part of the talk as a general overview of the vaccination experience in Israel, some of the challenges they faced, some of the advantages that they had. And then we're going to dive into the science and see some of the interesting challenges that we faced in this study. Then we're going to try to leave time for questions at the end. I also want to thank Ken for just creating an amazing environment at CHIP so we can conduct these amazing studies and collaborate with people around the world. And also to all my colleagues at CHIP for helping to create that environment. Okay, so let's get started. So here we are. This is Planet Earth. Planet Earth went through a rough year, primarily due to this other spherical object, which you may have noticed in the news, SARS-CoV-2, the coronavirus that has basically taken the world by pandemic storm. I don't need to speak at length about the effects of the virus and the pandemic, but I will highlight the fact that we're now in hopefully what is the final phase of this major pandemic, which is the vaccination phase. In record time, a number of companies, through a lot of collaborations around the world, were able to innovate in record time, test in record time, deploy in record time these vaccines. And one of them, which we'll talk about now, is the Pfizer vaccine, which was used here in Israel. Let's talk a bit about Israel so we understand the setting of this study. Here's planet Earth, at least the one half of it. Israel's right there in the middle, right in between three continents, Europe, Asia, and Africa. There it is again, bottom right. And here it is. Israel is an interesting place. As you can tell, most of it is actually desert, but the kind of fertile, populated, densely populated area is right here in the middle along the coast. That density is a really interesting factor. I know many of the listeners are in the US, so I'll use the United States as a comparator country here, although I imagine people might want to use their own comparisons. So Israel is a small country of 9 million people compared to the United States of 330 million. The area is pretty small, usually compared to the size of the state of New Jersey. But if you pack this many people in this area, you get a pretty high density. And that density is, you can see, over 10 times as dense on average as the United States. Obviously, there's variability as many people live in cities, some live in rural areas, but those are the overall numbers. I will add that the population density has been shown by many studies to be a key factor in overall spread of the coronavirus for obvious reasons. Another big difference between Israel and the United States is the population pyramid. So for people who are not familiar with this kind of demographic view, what you have here are age groups going up the side here and percentages along the bottom. And what we see here is that the United States has a pretty even spread of young people, middle-aged people, old people. And when you get to the kind of extra old people, people over the age of 80, 90, et cetera, you start seeing smaller numbers. Israel has a similar tapering at the top of the demographic pyramid, but the main difference is down here in the first few tiers, if you will, of the pyramid. Israel is a very, very young population. In fact, for the purposes of vaccination, as you all know, the Pfizer vaccine was approved or has been approved so far for use by people age 16 and over. And so when we talk about vaccinating the entire population, what we're actually talking about right now is vaccinating the entire eligible population. Because there's so many young kids in Israel, they make up actually almost 1/3 of the population. So 1/3 of the population in Israel is not actually eligible for the vaccine. And that makes universal vaccination of all eligible people that much easier because it's a smaller percentage of people that you have to vaccinate. The United States, if you were to compare the same age group, you'd get somewhere around 20%. So here, 1 out of 3 people is a kid. Here, it's 1 out of 5. So that's important to keep in mind as we move forward. How did Israel do? So a lot of people are looking at these world comparator stats sites, trying to compare how different countries fared. Obviously, there are many factors that go into determining when the pandemic struck a country, whether or not it locked down, how densely packed the population is, how much compliance there was, et cetera, et cetera, et cetera. But the numbers are what they are. Israel so far has 800,000 or so confirmed cases, and obviously those are only the ones that are tested. Israel's seen just over 6,000 deaths so far, many in the past couple of months, actually, ironically, just as the vaccination was happening. We'll talk about that. And if you were to divide the total deaths by the total population, you get to 670 deaths from COVID per million population. The numbers for America here are obviously larger. It's a much larger country. But if you look at the comparative number, there's about 3 times, give or take, maybe slightly less than 3 times the deaths per million. Okay, so how did we get here? What does this mean? And what was the study about? So Israel is different in another way. This is a recent headline from February from the Jerusalem Post. It says, Israel leads the world in time spent in coronavirus lockdowns. I've had the privilege of working with the Khalid folks here on site for the past few months. So I was in Israel for some of these lockdowns. I can say that some lockdowns were more strict than others, especially the first few waves. Let's have a look at those right now. So again, just to give a context of what happened in Israel, here is the timeline since the start of the pandemic. And you see February 2020 right here, and we are here in March 2021. So you see that Israel's basically had 3 waves. The first one right when the pandemic struck about a year ago, the second one in the summer, and the third one actually very recently in the beginning of 2021. If we were to overlay the lockdowns on this map of time, you'd see that Israel had a pretty long lockdown, a very strict one in the beginning, one over the summer, and one more recent one. And finally, Israel has been vaccinating, and it started its vaccination campaign right here in December at the end of last year and has been going strong since. So let's look now at that vaccination campaign, and that should help us wrap up this first part of the talk. So the following few slides are taken from, excuse me, the following few slides are taken from the Israel Health Ministry website. And what we see here are the vaccinations per day, starting in December, January, February. The dates are backwards. They're European dates, so the month comes second for American viewers. What we see here, the dark colored bars are the first doses, and then they're followed in similar shapes, if you can see over time, by these light colored bars, which stack on top of them. So here were the first few weeks of the campaign where a lot of the elderly rushed to get the vaccines. And here they are getting their second doses exactly 3 weeks later. So the shapes kind of copy each other. And since then, Israel settled on initially about 150,000 total shots per day, now about 100,000 shots per day. This is the cumulative chart. The reason it goes up to 6 million is if you take 9 million and you take out the kids, which is 1/3 of the population, the eligible population is 6 million. So Israel has vaccinated with a first shot almost 5 million people right now, or some say over 5 million people. That is obviously more than half of the total population, but more importantly, it's a much greater percentage of the eligible population. And you see the second dose curve, which is this light green line, following suit right afterwards. And here is the current stats. So this is by age group. These are the 90-year-olds, the 80-year-olds, et cetera. And again, dark green is first dose, light green is second dose. So you see that for the top 3 age groups here, Israel is doing pretty well. It's vaccinated over 90, almost 95% with the first dose. For the 60-year-olds and 50-year-olds, it's about at 85, almost 90%. And then kind of decreasing numbers for the younger folks who obviously were not the first to be vaccinated, but joined thereafter. Here's the current comparison chart with various countries. This is the one I pulled off today from Our World in Data, which I guess is a website that's had a pretty good year. Everyone seems to be using it now. So according to Our World in Data, comparing these countries, Israel currently leads with the total number of shots given per 100 people. And as you can see, the number in Israel is over 100, which means because people get 2 shots. So we've vaccinated over half of the total population. This is not eligible, but rather total. There are other versions of this chart, which include Gibraltar. And I have to, I know there is a viewer here from Gibraltar. So out of deference and respect, we do need to mention that Gibraltar currently leads Israel with total shots given per person. For some reason, it's off of this chart. Okay, how did Israel do it? So there have been a number of articles and kind of semi-documentary reports about the vaccination campaign in Israel. And some of the enabling factors that have been highlighted by some of these reports are Israel is a small, compact country, so it makes it easier. Number 2, they had vaccines. This is not listed, but obviously they were able to get the supply, which was kind of a circular argument because Israel did so well in distributing and deploying its first batch of vaccines. It was able to convince Pfizer to give it the remaining batches in a timely fashion. Israel has universal health coverage through 4 competing HMOs. It's a very interesting system. It seems to work pretty well. So nearly everyone in Israel is covered by one of these 4 HMOs. It's kind of a voucher system, so you can switch between the HMOs if you wish. but people tend not to switch so much. Family groups tend to cluster in these HMOs. They have excellent digital health systems. Israel is a kind of a nice combination because it's also startup nation, but it also has this kind of kibbutz socialist history. It's a nice combination of universal healthcare and high tech. So they have excellent digital health systems which include the ability to send targeted outreach messages. Also, interestingly, this is maybe a soft factor. Israel has a willing public. The Israeli public is experienced with collective responses to public emergencies. Obviously, it's an area of the world that has seen no small amount of emergencies, and therefore the public can kind of stand up and be counted when they're called to do so. So this is the setting, and now we're going to transition to the second part of the talk, which is the study. So the last slide I want to show, I guess, to introduce the study is the vaccination campaign. So what you see here is the same blue chart of cases over the last year and a bit, but the red line is the number of people getting their second dose. So if you can see here, the vaccination campaign started at the end of December. And here people start getting their second dose, obviously 3 weeks after their first dose. And you see that that's climbing very quickly. That's due to that big wave of elderly individuals that we saw getting their second dose then. There was a very interesting sense of case of timing happening here when people were looking at this happening in real time. The government was saying, hey, everybody come and get vaccinated. And at the same time, the news was saying the number of cases keep going up. And remember, the vaccination campaign started here, and hundreds of thousands of people were getting vaccinated with their first dose. And yet cases were going up and up and up. There was also a lockdown at this period. And so there was a very difficult task of public messaging and communications, public health communication here, because the Israeli public said, wait, we're locked down in our house. All these people are getting vaccinated and cases are shooting up to the highest they've ever been. What's happening? So it turns out it's a case of very bad timing. The British variant, as it's known, or inside England, it's known as the Kent variant. I'm not sure if there's a name for it inside Kent, where they might call it the high street variant. I'm not sure which part of Kent it's shown up in, but the British variant, known scientifically as the B117 variant, struck Israel at this point and started spreading very rapidly. And so during December and January of the past few months, we started seeing the British variant take over essentially the Israeli caseload to the point where by the end of January, it was estimated to be 80% of all isolates. 80% of all the new infections were the British variant, which is known to be much more infectious. And so there was a case of bad timing here, where just as Israel was locking down for its hopefully final lockdown, and Israel was conducting one of the world's leading vaccination campaigns, it was also facing its toughest wave to date. And that was very hard to explain to the public. But as you can see, once the second dose starts hitting, the numbers do indeed start going down. Here it is by age group. And you can see that this is also from Our World in Data. You can see that the elderly folks who are down here, they experienced proportionally a much greater drop, because they were the ones who were experiencing more vaccination penetrance in January. And the younger folks up here who were not getting vaccinated as much as quickly initially experienced less of a proportional decrease, but obviously that came later. Okay, so let's get into the study. What were the motivations for the study? So there has been a clinical trial for the Pfizer vaccine that was published in the New England Journal last year in December. And it included 22,000 individuals that had received the vaccine, 22,000 people that had received a placebo. And this is a classic randomized controlled trial. Modern medicine and modern epidemiology is a pretty mature field. And when it's important to get a very clear scientific picture, modern medicine and modern epidemiology offers the randomized controlled trial as the gold standard method for determining the efficacy of a drug or a vaccine. However, it's limited. It's only 22,000 people that got the drug. The people who participated were relatively healthier and younger than the global population, or at least the population who are at risk for the drug, for the coronavirus infection and severe disease. Within the randomized control trial that Pfizer ran, there was a strict adherence to vaccination protocols. There was very highly curated logistics and keeping the vaccine cold, et cetera. So everything was perfect, quote unquote. It's also a relatively small sample size, which means it's kind of hard to evaluate vaccine effectiveness for rare outcomes. It's also hard to do it for subpopulations, meaning if you want to know, well, what about cancer patients, or what about pregnant women, or what about people who are diabetics? How does the vaccine work for them? So it's harder to do if you don't have enough people in each group. So we did this study, as I said before, in partnership with Clalit. Clalit led the study. We were collaborating with them. Clalit is the largest of those 4 HMOs we mentioned earlier. It's over 100 years old. It has over 4.7 million members, which is more than half of the Israeli population. It's both a payer and provider. It has a low attrition rate. And again, it has these great electronic health data going back over 20 years. I mentioned Ron Balitzer before. This is in no small part due to his vision years ago that enabled the infrastructure that we have today to perform this study. Okay, so what is in this data and why does it enable us to do this real world vaccine effectiveness study? Well, we have anonymized data on a large cohort of individuals that includes demographic information, things like age, gender, neighborhood where you live, longitudinal medical information. This is basically medical history on these individuals, again, all anonymized. And we have, most importantly for this study, near real-time data on the following things: vaccination status, which is who got vaccinated and when, PCR tests for COVID-19, so you can figure out who's getting infected, outcomes, so you can figure out who's getting sick, including serious illness, hospitalization, and death from COVID. So you have both the background information on the individuals, and you have the study information on who's getting vaccinated, who's getting infected, and who's getting sick. And those are the pieces that you need in order to conduct this study. And we were very lucky to work with Clalit because they have that data. Okay, so how did we conduct the study? We're looking at only individuals 16 years or older. Obviously, those are the eligible ones for vaccination. We're looking at those not having previously documented positive SARS PCR test, SARS-CoV-2. In other words, if you've already been infected and you've recovered from COVID, well, you're probably not going to get vaccinated, and we left you out of the study. And we only looked at individuals who've been a member of Clalit for the last 12 months. So we have some sort of medical history for them. Okay, exclusion criteria. So we left out individuals where we didn't have a documented or clearly defined place of residence, so that you'll see why that was important for the matching. We left out people who had interactions with the healthcare system during the preceding 3 days. Those are people who are involved in some sort of health event, and that may affect a lot of things downstream. So it kind of made the data very messy. So we left those individuals out of the study. Nursing home residents for various reasons that if we have time, I can get into, as well as persons medically confined to the home. They had different risks of getting infected. They had different access to the vaccine. So they too were left out of this study, as well as healthcare workers. They had very high infection risk, obviously, and also differential access to the vaccine. So that's what we did. We looked basically at members of the general population who are not in these specific groups. And here comes the important part. Okay, so this is the study design. What we did is we divided the population that was in this study into 2 groups, those who got the vaccine and those who didn't. And then in order to compare the 2 groups, we matched individuals based on a whole set of criteria. We matched on age, gender, or sex, neighborhood of residence. Now note that's not city, that's neighborhood. So if you live in a large city like Tel Aviv or Jerusalem, the matching was done based on the individual neighborhood, which may be as small as a few streets. We looked at a person's inclination to get vaccinated, and we did that by, we estimated that by looking at their history of influenza vaccination during the past 5 years, how many shots they got. Pregnancy status, conditions defined by the CDC as risk factors for severe COVID-19, basically how many comorbidities you had, and the sector, basically which sector they fell into. This is very, very, very much conflated with neighborhood, but Israel has pretty clearly defined sectors that have pretty different lifestyles. We're talking about ultra-Orthodox Jews, Arabs, general Jewish population, and they have different risks of infection, different risks of exposure due to kind of different communal structures, etc. Okay, rolling cohort design. Because Israel was doing such a good job at vaccinating so many people so rapidly, it actually made the study more difficult. Because when we recruited, let's say, a person into the study, that just means that the computer identified someone who had been vaccinated, that someone was matched to an unvaccinated individual with all the kind of similar characteristics, lived in the same neighborhood, same age, same sex, etc. Well, what would happen if that matched unvaccinated individual a few days later got vaccinated? That happened a lot. Well, we have to censor the pair. In other words, we have to get rid of these two people, exclude them from the study because we're no longer comparing vaccinated to unvaccinated. And then the newly vaccinated individual we would need to find a new unvaccinated individual to match to them because they crossed over from the unvaccinated to vaccinated group. So that made for a challenging study because Israel was so rapidly vaccinating people, and vaccination progress also tended to cluster within communities. So if there was a certain community that was vaccinating very quickly, that actually made it tougher because in that community, it was hard to find individuals to match against the newly vaccinated individuals. So those are some of the challenges. Here's a chart, which we won't go into in great detail, but it comes down to these numbers over here at the bottom, where we found about 600,000 individuals in both the vaccinated and unvaccinated group, where we were able to match them using those very, very strict criteria. And about 86,000 individuals were transferring from one group to the other because they, as I just described, they got vaccinated after they were already matched. Okay, here's a bit about the study population. You can see in the unvaccinated controls and the vaccinated controls, they're very perfectly matched. So if you kind of separate them out by age group, you see that the numbers are identical in each age band. Same thing for the genders, et cetera, et cetera. And so the numbers here are identical because the matching was done so carefully. Here is also a further detail of the degree of matching. And you can see that for all these conditions and various health histories, there was also very tight matching according to all these criteria. Okay, what did we measure? Well, once we created these two cohorts, the vaccinated and the unvaccinated, we wanted to see what would happen to them. So we looked at these outcomes. We looked at documented infection, and we looked at, we'll get to that in a second, documented infection. We looked at COVID-19 illness, which is symptomatic infection. We looked at hospitalization, we looked at severe disease, and we looked at death, mortality. So these are increasing levels of infection and illness with the virus. So documented infection is a fancy way of saying this person was infected with the virus and then got a positive PCR test. It's by no means all the people were infected because not everyone got tested. A lot of people were asymptomatic. So this includes asymptomatic people who got a positive PCR test, but it excludes a whole bunch of people who were asymptomatic, did not get tested. So it is what it is. It's the documented infection outcome. COVID-19 illness is someone who is both infected, gets a positive PCR test and is showing symptoms of COVID-19. Hospitalization is what it is. People admitted to the hospital because their illness warrants it. Severe disease is someone who their condition degrades to the point where they go down to, if it's ARDS or some other more severe form of the COVID-19 illness, and mortality is related to COVID-19. So these are the various outcomes that the vaccine is trying to prevent. And they are the outcomes that we compared between the two groups. We also looked at different follow-up periods of interest. And these are the different day ranges, right? So we looked 2 weeks after your first dose, which is when it starts kicking in biologically, 3 weeks after your first dose, which is basically when most people got their second shot, and then a week after your second dose, which is when the full vaccine effectiveness kicks in. I won't delve too deep into this just in the interest of time, but this was the statistical analysis that we performed. Very briefly, we checked to see that the two groups were evenly matched using a whole bunch of factors, which we showed in that table. We used the Kaplan-Meier estimator, which are basically these survival curves that you'll see in the coming slides. And we calculated the vaccine effectiveness basically as 1 minus the risk ratio, which you'll see as well. And we also calculated the 95% confidence intervals using a bootstrap method. Okay, and here are the results. So let's see if we can understand these curves. The red curve is the unvaccinated group. The blue curve is the vaccinated group. And the x-axis is time. And here we're looking at documented infection, which is basically how many people got a positive PCR test. So we'll get to the numbers in a second, but let's look at the lines. So you see that in the first 2 weeks, this blue line, which is the vaccinated folks, and the red line, unvaccinated folks, are pretty much together. After the first 2 weeks, after 2 weeks after the first dose, they start splitting, start diverging. The red line continues to go up because these people are unprotected, unvaccinated, and therefore they continue to be exposed to the risks of being infected, and the total number of infections goes up. The blue line represents the vaccinated individuals, and you see the vaccine protection starting to kick in. So the upward trend of the blue line slowly flattens out until over here, which is the second dose is at 21. A week after the second dose is right here, and you see that following day 28, the line is almost flat. And here you see the actual numbers of people who were for whom we had person time in each of these time windows. And here you see the cumulative number of events. And the important number to see is in this bottom row, that once at 21 days, at 28 days, this number stops going up. It pretty much stays where it is. So whereas it had been climbing up very rapidly, here it flattens out. So that's for documented infection. Here's for symptomatic COVID-19. This is people who not only have a positive PCR test, but also have symptoms. And you see, again, same kind of picture. The blue line gets flat, the red line keeps going up. This is very impressive effectiveness for the vaccine. Same thing with hospitalization. The numbers are smaller here because fewer people overall are getting hospitalized. You see the confidence intervals getting a bit bigger because the numbers are smaller, but you see these numbers basically stop moving. 108, 110, 110. That blue line is no longer getting more people, whereas the red line keeps going up. And finally, severe COVID-19, same story, and death. Death was obviously the rarest outcome, and therefore the numbers are smallest, and therefore the confidence intervals are largest, but they still don't overlap. It is a significant finding. This is the same results in numerical form. What you can see is, for example, if we look at symptomatic illness, the time period goes down as you go down the page. So you see that the vaccine effectiveness, 57, 66, 94. So after your first shot, you can get to 50 or 60% protection, whereas after your second shot, waiting a week, you're up to 94%, 92% for severe disease. We also looked at subgroups, and we're gonna wrap this up in the next few slides, so we'll have time for questions. So we also looked at subgroups. So this is basically looking at the same statistics, but for only men or only women or different ages. And you basically see the same trends. If we're looking at documented infection or symptomatic illness, you see that for both men and women, for all age groups, you see the numbers go up over time. As you've had more time, you had both doses, and the vaccine has had time to do its thing. And we also see, very importantly, that it works for elderly people. The randomized controlled trial that Pfizer published initially in December included only a small number of people, and therefore it did not fully answer the question of what about the most elderly people? Do they have the same amount of protection? And the answer from this analysis is yes, they do. It affords great protection to most elderly folks. Continuing that same table, this is looking at individuals with existing conditions. In other words, these are people who have other illnesses. And we see that the numbers for them, especially those who have 3 or more coexisting conditions, even after 7 days, following the second dose, the vaccine effectiveness is slightly lower, at least according to this study. So the confidence intervals are still a bit wide. So at least according to this study, we don't know that for sure, but we see that there's an indication that for very sick people, the vaccine might be slightly less effective, although 89% is still pretty darn good. And then for other conditions, we see obesity, vaccine works great for people with obesity, people with diabetes also works great, etc. So those were a number of subgroup analyses that we did. So I want to get to one more kind of wrinkle in this great challenging study. And it's an interesting wrinkle that we had to come up with the team together came up with a very cool solution for. So there was a confounding effect that we experienced here. And that was that the folks who chose to get vaccinated, right? Because when the government said, okay, everybody over 60 can come and get vaccinated, not everybody over the age of 60 came. Certain groups, certain areas, certain people from certain regions came in much larger numbers than others, even though it was offered equally across all sectors, across all age groups, et cetera. Sorry, not across all age groups, but across all geographic regions. So what were the differences? Well, we noted demographic differences, geographic differences, health status, cautiousness. There's a lot of technical words here, but I'll give you an example. Pretend that there is one community, we'll call it the easygoing community, that is not taking the virus so seriously and maybe doesn't adhere to wearing masks so much, doesn't adhere to the lockdown so much, is not so worried about it, and similarly is not so rushing to the same extent as others in order to get vaccinated. So that's an easygoing community. Now let's say there's a much more, I don't know what we would call them, the non-easygoing community, the compliant community is saying, oh, I'm very fearful of the virus. I'm going to stay at home. If I leave, I'm going to wear a mask. I'm going to keep my distance. And as soon as the vaccine is ready, I'm going to go get it. So that sounds like a reasonable scenario, that some people might come from an easygoing community or background, and others might take the whole pandemic and its implications more seriously. This makes the study pretty hard to conduct, because if you were then to say, okay, let's compare this person who's 70 years old and male from the easygoing community to the person who's 70 years old and male from the non-easygoing community. Well, we're going to have some issues there, because as soon as the non-easygoing community guy gets vaccinated, he's protected. So you're going to hope to see an effect there, but you're going to see a much larger effect than the vaccine is actually giving you, because the person who didn't get vaccinated is also at a much greater exposure risk for getting infected. And therefore, you're going to see much higher rates of infection in the easygoing community, not because they're not vaccinated, but because they're being less careful. And so this confounding of the willingness to get vaccinated and the compliance with certain public health measures made the study more challenging to conduct. And so what we ended up doing, and here's one example of it. If you look at socioeconomic status was one of these confounding variables. So the black line here is, this is about a month and a half ago, black line is how many people overall of all eligible people in that community got vaccinated. And the red line is how many of the elderly got vaccinated. And over here you see the infection rates. What's very, very interesting is that in the high socioeconomic communities, there was a lot of vaccination compliance and very low infection to begin with, even before the vaccination started. Whereas for the low socioeconomic community, you saw very low vaccination compliance and high baseline infection rates. So this makes it very challenging to compare vaccinated individuals to unvaccinated individuals across these communities. So if you were to only match on age and sex, in other words, not do the full matching that we did, you'd get a line that looks like this. From day one, the unvaccinated community, unvaccinated cohort is getting much more sick than the vaccinated cohort. And that gives you a false sense of vaccine effectiveness. That's not due to the vaccine, but is due to just the different lifestyles, proclivities, and decisions made by these two groups. When you do the matching using our method, which is a much tighter matching, which doesn't match across communities, but only within communities, you get that nice tight following of the red line and the blue line for the first 2 weeks, and only then they start splitting. And that makes biological sense because that's when the vaccine is known to start kicking in. So we've just hit the 40-minute mark, so I'm gonna stop giving you more information, and I'm gonna hand it back to Ken, who might be able to take us forward to the question period.
Fantastic. Ben, such an important study, and so great to hear it directly from you. It's really very interesting, especially what you were just talking about around the kind of the nature of the real world population and the risk factors that they have or prior probabilities of infection in the first place that might confound the study in various ways. Now, well, we don't usually think of that kind of variation in a well-controlled FDA-style clinical trial. It was there in the clinical trials as well, because we were just looking at disease, generally moderate or serious disease, certainly not asymptomatic infection in those populations. And there were different variants and different prevalences of virus in those settings. So how do you think what you've been learning about the real world data should actually inform our level of either confidence in or some additional questions we should be asking about traditional clinical trials, where what we see is these real world effects were very much in play there as well?
So that's a great question. Can you see, I've stopped sharing my screen.
Yes,
okay.
everything is perfect.
Okay, great. It's a great question, Ken, and thanks for it. There is a great, interesting field of study which looks at the interplay between these randomized controlled trials and these quote unquote real world studies, or more technically known as observational studies. In this study, those last few slides that I showed highlight how the information that we gain from the randomized controlled trial help inform the observational study. But you're right, Ken, that it works both ways. And now that we saw that if you're not careful in the observational study, you can get all these confounding effects, it should inform future RCTs, randomized controlled trials, to make sure that they are correcting for all of these behavioral or exposure risks. And there is a whole field in epidemiology that is constantly refining what an RCT looks like. There's adaptive trial design. There are many other cutting edge questions, but the one that you raised, Ken, is a great one, which is how do you get rid of the confounding? And it's very hard to measure, especially with limited sample size. So the answer is that we can use all the help we can get, and it's important to use both observational and RCT trials in order to get a full picture.
Great. Let me reward the early bird who had a question in the chat even before your talk began. You're thanked for the talk. And I'm going to ask about the second part of the question and relate it back to some of the deep dives you took us into the tables. The second part of the question was, any groups such as immunocompromised ulcerative colitis patients have any issues with getting the vaccine? And I'll just point out there that you showed us a slightly lower efficacy rate in multiple comorbidities, which may well relate to immunosuppressive medications, for example. So take it away, Ben.
Okay, great question. So the short answer is stay tuned. We had a lot of people in this study when we submitted it about a month ago. We have even more people that we can study now. So we are currently analyzing and hope to soon report additional subgroups that we didn't have enough sample size for when we initially published the data. And there's the kind of dilemma we had, which is, should we wait around and get more data on additional subgroups, or should we get this out there? And at a certain point, that decision was made to get it out there. Immunocompromised individuals is one of the groups that we're looking at. So hopefully soon we will have data that we can share in an update about that group.
Great. And question from Adam Culbertson. How much higher could the actual cases of COVID be compared to the confirmed cases?
Okay, great question. So there has been a great study by my CHIP colleague, Maurizio Santinaya, who has published a great paper about different ways to estimate that, which basically asks the question, by how much are we underestimating the true rate of COVID infection using these confirmed tests? And obviously it depends on availability of testing and many other, and decisions to going and getting tested. So it's a really interesting question. It's a complicated one. I refer you to Maurizio's recent paper, which is a fascinating and a very good treatment of the question.
Great. I have a question about whether there's data collected that would be relevant to the question of sterilizing immunity. So this also relates to this idea of whether we're completely eliminating infections or not.
Mm-hmm. So great question. There are certain things that are difficult to study in an observational study because it's not a randomized controlled trial. It's not a curated kind of playground or sandbox in which we can control every factor. Because we're not doing testing, universal testing on every individual in Israel every day to determine whether they've had COVID-19, whether they just got it, we are not able to answer most of the questions about asymptomatic infection or transmission. There are other studies going on, including in Israel right now, that are creating these curated environments within the real world through which we can start to answer the questions about, including sterilizing, vaccination effects, and transmission effects. So this study is not that. There are other studies going on that hopefully soon we'll be able to give a good scientific answer to that.
Great. There's a question about whether you have any further information on the 2 to 3 people who are hospitalized or died after the second dose.
Great. So the data, so this is very important because obviously it's a politically charged issue and there are public debates going on between people who are less enthusiastic or more cautious about vaccines than others. So I won't delve into those waters. I know they're turbulent waters. I will say that a very, 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 very large percentage of the people currently, now that Israel has achieved a very high level of vaccination, the Israel Ministry of Health just aggregated data from all the hospitals across the country, and almost all of the people who are currently hospitalized were unvaccinated, and that is in its own right the result that the vaccination campaign was aimed at achieving. Now, there is a question, which is, what about breakthrough? Are there individuals who are, even though they're vaccinated, they still get infected? Well, the answer is yes. The numbers are not 100%. They are 92%, 94%, 95%, depending on which study you're looking at, depending on which outcome you're looking at. So even the studies that say the vaccine works really well, including this study, do not say it's 100%, but 95% is pretty darn good. It's important to understand what that 95% number means. It doesn't mean that you are 95% protected. it probably means, and there are different interpretations of it, the one that I think is most intuitive is 95% of the bad things that happened to the unvaccinated group are not going to happen to the vaccinated group. So you're kind of, the total number of negative outcomes are cut by 95%. Why are there still 5% or so negative outcomes? It could be that the individual who got vaccinated didn't have a strong enough immune response to the vaccine, to both doses, and didn't develop a strong enough immune system protection. It could also be that that particular individual received a very heavy dose of the virus, and they had some level of protection, but not enough to overcome a very large dose of the virus that they were exposed to. And perhaps most interestingly, it could also be related to variants. As we all know, we've all heard of the British variant, the South African variant. I see someone from South Africa is on the call as well. All these variants have scientific numbers, but they're referred to in the media using these countries in which they were first discovered. There's now a New York variant, which has certain similarities to the South African variant. There's a Brazilian variant. Eventually, I think every country will have its own variant named after it. And there are indeed dozens, if not hundreds, of other variants that are not in the news, and just because they don't show any extra levels of danger. But there are now studies going on that are looking at whether certain variants are able to penetrate this layer of vaccine protection better than others. There's still some concern that the South African variant is able to penetrate more than the other variants. It is by no means yet a done deal. We still need more data about it, but it's still something that's actively being studied. And a country like Israel that's achieved a certain level of protection, its greatest fear right now is that a variant will evolve or emerge that will break through, that's the scientific term, this protective barrier of the vaccination. Evolutionarily, there's nothing stopping the virus from doing it. And the hope is that if and when such a variant would evolve, hopefully not soon, the vaccines could be modified to cover it as well. It may sound scary, but that's actually what has been going on for the past few decades with the flu vaccine. The reason one needs a new flu vaccine every year is in part because there are new variants evolving. So it's not such a scary outcome that we'll have to get an annual COVID shot to follow those variants. Back to you.
Yes, so there are many good questions. We won't get to all of them. I'm trying to give us a variety. This one is interesting. I don't know if you can answer it with data, but it's an interesting question. Will there be any way to tell what happens to your vaccine success rate based on your local cohort? So if 10% of your friends are vaccinated, the effectiveness is 70% versus 90% if all of your friends are vaccinated.
Okay, so you're saying does your immediate circle of friends and their vaccination status, does that affect your overall risk of getting sick?
Yeah, can you tell?
Yeah, so the answer is logically it would seem that yes. It's very hard to study again because you need to understand, you need kind of a rigorous method of identifying who are your circle of friends and how often you're exposed to them. One proxy for that is households, and there have been study designs suggested where if one has information on who lives where, that could be a proxy for circle of friends, as it were. And then you can see if there's herd immunity within a household, if you will. The numbers are pretty small, but so there's some design challenges there. But it's definitely an interesting question.
And a question from our mutual CHIP colleague, Zoltan Szilagyi. Why are your unvaccinated numbers also seeming to flatten out with a few weeks delay?
Okay, that's a great question, Zoltan. That is because when we published that study, as you get further away from the beginning of the follow-up period, more and more people drop out. And they're not dropping out because of various exclusion reasons, they're dropping out because the study ended. We submitted the study with data up until the beginning of February, which meant that there wasn't much follow-up time in those later categories. And so the reason you're seeing the overall counts go down because those are absolute cumulative counts, what you're seeing there. The reason you're seeing those go down is because the people who made it that far in the study were people who got vaccinated really early, and there weren't as many of those as people who made it 1 week in, 2 weeks in, et cetera. And so it's a artifact of the way it's plotted and the way the data was collected. I can say that we've been rerunning the analysis since then, and we have much more person time since then, and it's looking just as good. And we hope to update the results soon. So yeah, that's the answer to Zoltan's question. Maybe we have time for one or two more.
Yes, here's a question also pointing to potential future analyses, I think. The design of the observational study is impressive. Is there sufficient data to estimate the side effects of the Pfizer vaccine? And how do these data, and will those data be used in the vaccination campaign in Israel?
Great question. So vaccine effectiveness and vaccine safety are paramount. They are the two things that one wants to know about a vaccine. And you know, what most people maybe aren't aware of is that the Pfizer vaccine, similar to the Moderna vaccine, both of which use the mRNA platform, different mRNA platform, they were ready about a month or two into the pandemic. They were ready a year ago. The reason they haven't been released is essentially, and this is a very oversimplified statement, that they've been tested. They've been being tested for effectiveness and for safety since then. And so that was most of the delay. One of the scientists was interviewed who had taken a key role in designing the vaccine. And he said that basically 1 weekend after the Chinese government released the DNA sequence, he already had the vaccine designed. So that's what we've been doing. That's what the drug companies and others have been doing since then. We are currently conducting, the same group of folks are currently conducting a safety study on these same data. And we hope to release that soon. Other safety studies that have been published all seem to agree that this is a very safe vaccine. And so far, there hasn't been any reported side effects that are surprising or very common in any of these studies. And there's a lot of monitoring going on in America, in Europe, in Israel, and around the world of all these individuals who are getting vaccinated. Tens of millions of people have already been vaccinated. And so far, there's no great surprises on the safety side. So it's an important message to communicate because people have legitimate concerns about side effects. But this seems to be an astoundingly effective and safe vaccine.
Fantastic. We are at exactly 3 o'clock. And so despite several intriguing questions left in the chat and the Q&A, we're not going to be able to get to them today. For people who are interested, the talk will be posted on the CHIP website under the events page and within a day or two. And someone asked, when can we do these in person again? And hopefully soon, and given how popular they are on Zoom, we might have to come up with a hybrid model for when we do have speakers in person. So I'll end it right there. Ben, thank you very much for a superb talk.
Okay, thanks. And thanks everyone for joining today. We appreciate the questions, and feel free to get in touch by email if you have any follow-up questions. So, right. Thanks, Ken, and thanks everyone.